So I'm very excited for our guest speaker today. So Dr. Jade Moon is going to be talking to us about diabetic retinopathy, current state and solutions. So Dr. Moon is a second-year ophthalmology resident at the University of Minnesota. She received her bachelor's degree and her MD from Harvard University, and her clinical interests include innovative ways to utilize ophthalmic imaging to increase access to care, particularly in the management of diabetic retinopathy and retinopathy of prematurity. So I am going to stop sharing here and pass it over to Dr. Moon to start. Thank you so much.
All right. Thank you so much for having me today. Again, my name's Jade. I'm one of the ophthalmology residents at the university. I'm going to start sharing if I can. Why won't it let me? Is it mine issue? Or sharing my screen. Present content only. It won't let me share for some reason.
Okay. The share button's up right alongside of the leave button in the upper right-hand corner? Okay.
I click on it and it doesn't give me an option to share.
Okay. Oh, that's interesting. Do you want to email it to me quickly and then I can run the slides
for
for
you?
you?
If you have the slides up, that's pretty, those slide decks should work. Otherwise,
the ones that you sent?
Yeah.
Okay, perfect. Yep.
Yeah,
I mean, go ahead.
Very minor changes, but it's not enough to cause it delay.
Wonderful.
Yeah.
You know, Teams is great when it works, but a lot of times there's some technical issues with Teams as well. So I will pull up those if you want to start talking.
All right, so again, my name's Jade. I'm one of the ophthalmology residents at the university, and the title of my presentation is Diabetic Retinopathy, Current State and Solutions. And I have no disclosures. I have no relevant financial disclosures. I'm not seeing my screen. Is it being shared already?
Nope, I'm just opening it up.
Okay, all right. Yep. I'll just wait for the slides to load.
Okay, wonderful.
And thank you so much again for having me here today.
Yes. So you should be seeing.
Yep, beautiful.
Yep, good. Okay, wonderful.
All righty. So again, I have no disclosures. And then if we could go to the next slide. And I'm seeing, I can just talk in the current mode. I'm seeing like the everything rather than just the slide deck itself. Like in a presenter view.
Let me see if this helps. I'm going to switch my screen here. Thank you all for being patient on this Friday.
Yep. Oh, there we go.
Is that better? Right. Okay.
Yeah.
Perfect.
So I first wanted to start this conversation by talking about what diabetic retinopathy is. Maybe it's a very obvious answer, but it is changes to the eye as a result of diabetes, diabetic changes to the eye. It's along with diabetic retinopathy, nephropathy, and other complications of diabetes we see. It is considered a microvascular end organ damage to the blood vessels in the retina. So we classify diabetic retinopathy in 4 stages. There's mild non-proliferative, moderate non-proliferative, severe non-proliferative, and proliferative, typically being considered the more severe form of this disease. Next slide, please. So what does that exactly mean? So there are several things that several changes that happen to the back of the eye as a result of diabetes. One of the most common ones is called diabetic macular edema, and this is just a fancy way of saying that the blood vessels and the retinal blood vessels get leaky and there's swelling in the back of the eye, and the retina, which is a neural part of the eyeball, kind of helps us see, and with the swelling that can result in decreased visual acuity. The second complication we see is neovascularization. So like with other changes of diabetes, diabetes results in ischemic changes in the smaller blood vessels in our body and different parts of organ systems. And when the body senses this ischemia, it sends a signal to have new blood vessels form. But of course, unfortunately, the new blood vessels that form are never, quote, normal blood vessels. There's something, they're aberrant growth of vessels, so cause a variety of complications, including but not limited to some hemorrhages, vitreous hemorrhage, glaucoma, and retinal, and in some cases, retinal detachment. Next slide, please. So diabetic retinopathy is the leading cause of visual impairment in working age population across the globe. And it is estimated that by 2040, approximately 600 million people worldwide will have diabetes. And of this number, about a third is expected to develop diabetic retinopathy, and about a tenth is expected to develop vision-threatening diabetic retinopathy. And maybe I'm preaching to the choir, but the best treatment is good blood glucose control. And there's one study that suggests that 1% reduction on hemoglobin A1C level results in 21% reduction in risk of various complications of diabetes, not just the eyes, but just any complication of diabetes. All right, next slide, please. So more specific for screening for diabetic retinopathy, there are multiple parts to the exam. This is kind of the common parts that I've laid out that's involved in many patients, but our exam is not limited to these 5 components. First, of course, we check the visual acuity using a Sullivan visual chart or other ways to check the visual acuity. We check the pressure in the eye, the intraocular pressure. We often get what we call the OCT macula, which is the scan that we see on the slide. And this helps us scan the back of the eye. So imagine looking at a cake, and you can look at the cake, the whole cake face down and kind of see the surface of it. Or you can take different slices and be able to look at the different layers of the cake. And what OCT does is that it allows us to look at the different layers of the cake with good resolution. So it's very helpful in assessing if there's any swelling in the back of the eye, because it gives us that cross-sectional view. And of course, there's the slit lamp exam, which is a fancy microscope that we use in the eye offices, and the indirect exam, which gives us a wider field of view of the back of the eye. So these are the 5 mainstay components of a diabetic retinopathy eye exam, though there can be more or less depending on when you present and how severe your diabetic retinopathy is. Next slide, please. So there are 2 large treatment options for diabetic retinopathy today. One is called pan-retinal photocoagulation, where you basically use laser to burn off some of the peripheral retina to control some of these complications that we see. And the other is intravitreal injection, which is an injection of anti-VEGF agent. So it works against the abnormal signaling that occurs in the eyes. And it's generally thought that the 2 treatment options achieve the same thing. So though there are some nuanced differences on when you would consider one over the other and the benefits of one over the other, but I won't go into too much detail about the 2 treatment options unless anyone has any questions at the end of the talk. Next slide, please. So now focusing on the US. In the US, only 1 in 4 Americans with diabetes are aware that they have diabetes. And unfortunately, for the eyes, screening compliance is less than 50%. But it is estimated, some research studies have shown that with adequate care, at least 75% of blindness that we see associated with diabetes can be avoided. Next slide, please. And of course, we focus so much on screening and of diabetic retinopathy because this is the lives of individuals that we're affecting. I mean, when you lose your vision, there are significant impacts to your quality of life. So it's very important on that individual patient level, but there is also a real economic burden for our society as a whole. So there was one study that estimated that appropriate treatment of diabetic retinopathy, and more specifically diabetic macular edema, achieved an incremental cost effectiveness ratio of over $12,000 per quality adjusted life year. And in another study in 2016, the study estimated that with appropriate treatment of diabetic retinopathy on patients that they were able to reach, the US saved about $1.6 billion. So of course, the first and foremost, the burden on an individual life and quality of life is very real, but the economic burden on our society as a whole is also very real. Next slide, please. So again, I'm preaching to the choir, but early disease identification and prevention is paramount. It's super important in reducing visual impairment. Next slide, please. And so on that note, I wanted to review the current screening recommendations, which differs a little bit depending on the type of diabetes you have. So for type 1 diabetes, because these patients tend to present shortly after symptom onset, shortly after the disease onset, eye exam can wait a little bit. So typically we recommend an eye exam within 3 to 5 years after diagnosis of diabetes. For type 2, on the other hand, these patients, the disease tends to be a little more occult, so that it tends to be detected a little bit later. So we recommend an eye exam at the time of diagnosis. So in patients with both type 1 and type 2 diabetes, we do recommend an eye exam soon after conception and early in first trimester of pregnancy. But in patients with isolated gestational diabetes without a pre-existing diagnosis of diabetes, we don't necessarily recommend an eye exam. Next slide, please. And this was actually a recent guideline that was published by the International Council of Ophthalmology and the American Diabetes Association in 2018, recognizing that while in an ideal world, we would have every patient be screened by an ophthalmologist or an eye care provider, because the gold standard eye exam is an in-person dilated exam. Nothing will compare to that, but recognizing that ophthalmologists may be a limited resource and it might not be a feasible option for all our patients. And so they created this table kind of stratifying what the screening schedule should be. And it kind of depends on the severity of the diabetes you have. And, it's the more severe it is, the more frequently we want to see you or be referred to an ophthalmologist. Next slide, please. So now focusing a little bit on our state of Minnesota, and I want to thank Bridget for providing me some of the statistics that I included in the slide. About 400,000 adults live with diabetes in our state, and this translates to over 130,000 patients with possible diabetic retinopathy and 40,000 patients with vision-threatening diabetic retinopathy. However, only 60% of adults with diabetes received their recommended eye exam in 2021. And only 20% of adults with diabetic retinopathy with a known diagnosis of diabetic retinopathy completed an eye exam in 2021. So as you can see, screening is really lacking and we're not reaching as many patients as we would like to. Next slide, please. So on that note, how do we increase rates of screening? And again, I will emphasize that nothing will beat the gold standard is an in-person dilated eye exam where you come to the eye office with an eye care provider who do a thorough 360 exam. But I recognize that might not be very possible for a variety of reasons. And I think there are a couple exciting solutions. Number one being telemedicine screening. So at the onset of COVID-19 pandemic, there was really a huge uptick of telemedicine use across subspecialties, including ophthalmology, kind of out of necessity, with all the distancing or social distancing that was going on, and with us triaging. This was really, I wouldn't say born because this model existed before that, but there was a huge uptake in use during the pandemic, and it was kind of out of necessity. But we did see that it may be a viable model of providing healthcare. So there's two models of telemedicine. First is synchronous, where the provider meets with a patient real time, virtually, whether it's via Zoom, FaceTime, Teams, whatever it may be, and kind of connect virtually to talk about some of the issues, some of the symptoms, perform a physical exam virtually, and come up with a plan and solution in that encounter. The second model is called asynchronous, also called store and forward model, where the patient gets all the necessary testing, whether it's blood work, imaging, whatever it may be beforehand, or messages their provider saying, hey, these are my symptoms, these are my concerns. And the provider at a different time responds to the patient in one form or another to kind of review the results, review the concerns, and come up with a treatment plans. So these are kind of the two models of telemedicine that exist kind of in our healthcare system. Next slide, please. In ophthalmology, several ophthalmologists across the country have advocated for this hybrid telemedicine model for us. And what this means is that first, patient obtains testing and imaging, whether at a primary care office or a testing center, whatever it may be. Testing results are then reviewed by ophthalmologists at, whenever they're able to, and then the provider and the patient connect via telemedicine, whether it's via the phone, on a phone call, Zoom, FaceTime, Teams, whatever it might be, to review kind of the results, and then together during that visit, come up with the follow-up plan on what the next best plan going forward. And there are actually some success stories with this model of care for diabetic retinopathy screening. Next slide, please. The VA system actually about a decade ago have implemented a diabetic retinopathy screening system where they kind of placed fundus imaging machines, so machines that can take images of the back of the eye at select primary care locations. And they have found that doing this has decreased the distance traveled that patients have to travel for an eye exam. And they were reaching more patients. They were screening more patients at an earlier stage of their disease. And the number of patients with the diagnosis of diabetic retinopathy and the awareness of the disease really went up. And the second success story is with the Indian Health Service Jocelyn Vision Network, which has been a group performing diabetic retinopathy screening exams on Native Indians and Alaskan Natives since 2001, I believe. And they've really been advocates of the store and forward model of diabetic retinopathy screening. Similarly, obtaining fundus imaging beforehand and having those images be reviewed by an ophthalmologist at a later date. Most recently, they have actually published a paper that suggested the use of multi-field fundus photography. So what this means is that the reason I keep emphasizing that the gold standard exam is an in-person exam but with a dilated eye exam is because as cool and advanced as our current technology is, it does not give us a full peripheral view. We cannot look at all parts of the retina. Our view is limited to kind of the central part of the eye. And with these fundus images, that's the big limitation of them. So what they've done is they've taken these fundus images with the patient looking straight forward and also looking in different gazes to kind of capture a wider field of view. So they were able to create larger images using the existing technology to kind of get wider fields of view. And their study has suggested that this multi-field fundus photography did increase detection by twofold and more peripheral lesions were detected. Next slide, please. And the second solution that I think is exciting is the use of artificial intelligence, which kind of is the current buzzword in all facets of society, not just healthcare right now. But it was really exciting in 2018 when the FDA approved the first AI-based autonomous diagnostic tool. And this actually happened to be for diabetic retinopathy screening. Next slide, please. So the product is called IDXDR, and the idea behind that is that you place these fundus cameras at primary care offices, and this program is able to analyze the fundus photo to give you one of two answers. There's mild to no diabetic retinopathy, so you can just repeat this exam in 1 year, or there's more than mild diabetic retinopathy, so the patient should be referred to an ophthalmologist as soon as possible. So this, applied artificial intelligence, and this was the first AI-based diagnostic tool that was approved by the FDA, which is really exciting for ophthalmologists. Next slide, please. But of course, there are some challenges that exist, as exciting as these potential solutions are. First is that, especially with telemedicine use, it does really require digital literacy. What that means is that patients need to have access to the technology to be able to connect with their provider, whether that's a cell phone, a laptop, whatever it may be, and they need to know how to use this technology. So there might be some challenges to this. And I think there was a recent paper that kind of reviewed telemedicine use in ophthalmology during the COVID pandemic that actually found that the buy-in for telemedicine showed a huge gap in care and exacerbated some of the discrepancies we see in care, where the historically marginalized communities were not utilizing these resources as much as communities that were not as marginalized. And we expect that to be a combination of different reasons, but having access to this technology is a luxury in and of itself. So that's a real consideration we need to take into account as we develop a way to use telemedicine responsibly in healthcare. It's exciting and it will certainly reach more people, but we need to be smart about how we do it. And second is, of course, we need physicians to agree to do this. Telemedicine is not a huge part of most residencies, most trainings for doctors, and many doctors practice way before we even started this conversation about using technology in one form or another. And maybe, so there needs to be some education how to perform a physical exam on using these technologies. What conditions are appropriate to be seen using technology, or what really cannot be replaced by an in-person visit. So these are some ongoing conversations that need to be had if we were to make this a more widespread thing. And last but not least, but equipment can be pricey. That fundus camera that I keep talking about, that's over $10,000. And as new technology comes out, you know, it can be more expensive. So there are some real challenges to this, as exciting as it is. Next slide, please. So in conclusion, everyone should get an in-person eye exam if possible, but there are some recent technological advances that are offering very real and exciting potential alternative models of care. And last but not least, burden of diabetic, I cannot stress enough that the burden of diabetic retinopathy on individual patients as well as society is very real and serious. Thank you so much for having me.
Wonderful. Thank you so much, Dr. Moon. Are there any questions that anybody in the audience has for her? One question I had, I've read a lot about mobile exams. Can you talk a little bit about so I'm assuming that the camera that you were mentioning is in a mobile unit that goes to different places?
So it can be that I think there are several models where sometimes I know the university has a mobile van health clinic where some volunteer physicians and medical students travel to those distant sites to provide eye exams. So I think at least within the university, that's one model that exists currently. But certainly, taking these cameras to different places and taking photos can be a real option, and having ophthalmologists review those images.
I'm just thinking about some of the more rural parts of our state and being able to reach some of those people who, it would be hours to get to a primary care. That would be great.
Right. No, definitely. So I think ophthalmology is a very imaging friendly field with a lot of advances in imaging that comes out every year. So I think it privileges us in that we can, as long as there's imaging equipment, we can image a lot of patients and reach a lot of patients. That being said, these equipments are pricey, and that is certainly a constraint that we have, though there are cheaper alternatives that maybe be lesser resolution images, but can be good viable alternatives as well.
Yeah. I see Jennifer had a question in our chat. So she's asking, should a patient wait to have an eye exam if they have a double-digit A1C? It's a great question.
Yeah, that's
And if so, how long should they wait? And then also, what about new prescriptions? I'm assuming back to that double-digit A1C.
As far as I'm aware, I mean, of course, we're not, if a patient comes in with a new diagnosis of diabetes, especially with type 2, we're assuming that they've had the disease for a while. So we would like them to be plugged into see an eye care provider right away. So the answer is yes. With type 1, because even if they come in with a double-digit A1Cs, my understanding of type 1 diabetes is that they don't tend to have this insidious disease process that goes on for a while before it's detected. It tends to be more acute onset. So it's not necessary. I don't think as far as I'm aware, it's not indicated necessarily, but I don't think any ophthalmologist would turn you down and say that exam is not indicated. But as far as I'm aware, for type 2, at the time of diagnosis, and for type 1, 3 to 5 years after the diagnosis is a recommended timeline.
Yeah.
And I'm not sure what she means by new prescriptions, as in new glasses prescription.
It looks like she's typing her answer. Yes.
So unfortunately, the changes to the eye that happen because of diabetes is not something that we can fix with glasses. So glasses won't really help these patients see better for the most part, because glasses kind of help us refine some of the surface disease, but changes in the retina, which is a nerve layer of the eye, unfortunately, no glasses is able to correct that. Although if patient has an overlying refractive error, of course, that can get their vision a little bit better. And the other thing to keep in mind is that if you're sitting at high blood glucose levels in the 300s, it can also actually cause swelling of the lens itself. So your glasses prescription might be changing even like from day to day or morning to night as the lens swells. So in patients with really high blood glucose level, um, you glasses might correct it a little bit because the lens is changing shape, but their prescriptions got changed hourly.
Yeah, okay. I think that's what Jennifer was getting at is
Yeah.
was the second part of your answer of getting a prescription right at diagnosis, and it may change
Yeah. Mhm.
soon after. So wonderful. Any other questions for Dr. Moon? And I have her slides, so I will send them out um, with the recording of the presentation. So you'll have those for your reference as well. All right, wonderful. Thank you so much for your time, Dr. Moon. I really
All right.
appreciate it.
All right. Thank you so much.
Yeah, have a good day.
Have a great day. Is it all right if I log off
Yeah,
now?
I know
All
you
right.
have other things to do. Yep.
All
Yeah.
right. All right. Have a
Thank
great
you.
day. All right.
Yeah,
Bye-bye.
thanks. Right. I have just a couple updates that I wanted to share with you. Let me just pull my stuff back up here. Okay. Sorry, I'm trying to get the right screen going here. So a couple upcoming in-person things, which is really exciting to think about doing something in person. We have the ADCES Minnesota Chapter Spring Refresher, and I have sent out some information about this recently as well, but registration is now opened. And the date of that is going to be May 3rd, so in just a couple weeks. I have kind of the brief agenda here, but if you go into the website, you'll find that the whole agenda is there and as well as kind of some of the logistics of the day. So hopefully most people can join that because I think the topics look wonderful. So very wide ranging topics. So I wanted to point that out as well. Another one I want to plug is one that I'm part of. We have our Many Faces of Community Health Conference coming up. We moved it to fall this year. So it's a 2-day in the beginning of October. And for those of you who aren't familiar with what the Many Faces of Community Health is, it's focusing a lot on health disparities and inequities and across the board in different types of health situations. So two things I wanted to point out is that we're currently looking for members of our conference content advisory group. So what that would be reviewing presentation proposals and then helping select what presentations that we're going to be giving on that day. And then also the day of the conference of coming in, helping with some of the speaker logistics. So it's a volunteer position. However, you get the 2-day conference, which is we charge $350 for the conference. So you get your conference fee covered for your participation in the group. So when I send the slides out, there is an application to be on what we call the CCAG committee. And then also we have a call out for presentations. So if you or any colleagues have anything that you think would be a good topic to have discussed with the very wide range of people that we get at the conference, this will also be a link for the application. It's pretty simple. And so I would highly recommend if you are interested to fill out that and come and be one of our subject matter experts at the upcoming event. A couple webinars that are recorded webinars that had happened recently, and I wanted to point out as well. I recently took part in the webinar about the new physician fee schedule ruling, and it's really has some promising things for using community health workers in our diabetes education programs. So they're having different ways to be reimbursable for community health workers in a supporting role within diabetes education, specifically for addressing social determinants of health and not only screening, but also probably more importantly, is connecting them to resources within the community. We can actually now bill for community health workers to do that type of service. So this is a link to the actual webinar. And then how food insecurity feeds diabetes was also a recent one that I watched. I thought was very good, as well as subsidized transportation and how that could slow diabetes progression. So those are both recorded ones. And again, I'll send these out if you have any desire to watch those. I also wanted to point out, kind of with our theme today of the eye care, ADA has the focus on diabetes, it's closer look at diabetes, and it has many, many modules for, some are specifically for eye care providers, some are for nurses, dietitians, support staff. So they have a ton of resources on eye health. And also some patient-facing information that is also available on that website. So I'll include that as well. Couple other things I wanted to point out. The CDC recently put out an updated marketing and promotion toolkit. So this has both written, patient education materials or provider facing materials for promotion of DSMES, as well as some social media that you can use. Pop in the name of your clinic and you can put it out there on your social media about the benefit of DSMES programming. And then along with that, we also have, this is put out by the technical directors of our current grant. It is an annual holiday calendar. And what it is it will give you information for social media messages, say on Thanksgiving. So it's a Thanksgiving theme social media post about the importance of diabetes management. And again, they're all able to put in your own clinic information and put those out there. So I know sometimes we don't sing our praises enough on social media. So these are a couple different ways that you don't have to invest a lot of time or effort into doing them. They're already done for you and then done well. So those are some options for some marketing of DSMES programs. I just want to open up for a quick once around if there was anybody that had any questions or concerns that they're dealing with this month.
This
I
is
have
Carrie at the VA, and this is,
Yeah.
I don't know if this is the right spot, but we are in dire need of educators. So we have a position that is open, and we're going to have another one open in another year. So if anybody's wanting to know what it's like to work at the VA, let me know. Or if you know anybody out there, I don't know, Bridget, if you have any, we had talked before about new people coming in,
Mhm.
that might want to get into this field. Let me
Yeah.
know, if
Yeah.
there's anybody that we could talk to.
Wonderful. And if you want to write something up, Carrie, like a little brief or attach a job description, I'd be more than willing to put that out there on our Basecamp listserv sites too. So
Okay.
it could get out to the providers who weren't able to be here today.
Okay, sounds good.
Mhm.
This is Linda Bartholomew. I just am wondering if anybody has any novel ideas for process improvement ideas or program improvement ideas for ADA recognition. We've been kind of doing the same one for several years and just looking for new ideas. We've been doing goal improvement, follow-up, and it just kind of is stagnant. So looking for something fresh.
So Linda, talk a little bit about, so you're previously did goals, like monitoring the goal, like individual patient goals. Is that what was your
Right.
process was?
Yep.
Okay.
So like when dietitians or educators see patients, we want them, when they're calling them back or seeing them back, to be following up on the goals and documenting that in a flow sheet.
Okay.
So that we, have our percent follow-up be improving. We're kind of depending upon the clinic. Some clinics are great, have even like 75 or 80% follow-up, which is phenomenal. Some are pretty stagnant around 30%, just depending upon the rural nature of the clinic and how difficult it is to follow up with patients. It's just hard to move the dial.
Yeah. Dawn?
Hi, Bridget. Kind of on that same theme with goals. I am stuck at, and I don't think I'm the only one, at how we are doing goal setting with our virtual classes, because we do that typically in our in-person classes, so it's virtual classes. And how do we set those goals and evaluate those goals when, you know, they're in a group and we don't individually connect with them?
Okay.
Something
Does
to think
anybody have?
about. Mhm.
Yeah, we do. Well, majority of our patients are seen virtually now, but we got set up so that there is an electronic version of like a goal setting form that they can fill out while they're in the class or right after the class, and then we would have access to that. And then we have one person who is designated to be the follow-up contact. So if that, because you know, not everybody comes to follow up, but if they don't come back and we can't follow up on that, this one person then calls everyone and goes through their goals to assess where they are. But it's that initial just getting the goal that was the big issue. So we had to find a way to get it electronically.
So when you mean electronically, is that just like sending an email, or not during that virtual class? I'm assuming.
Well, it's through our secure messaging. So I'm sure, you know,
Okay.
different facilities have different my charts and all that.
Mhm.
But it's a form that goes through that they can respond to or click on and type in whatever they want, and then it bounces back to us.
Cool.
So we would
Okay.
see it, you know.
Thank you.
Any suggestions for Linda, or can anybody talk to what they're doing right now for their process improvement to give her some ideas?
This is Don. I mean, just some ideas. We've always done access, you know, some goals around our access of our program. That always seems to pique the interest of administrators and things like that, because that's always something that I've been asked about, is how's our access,
Sure.
as opposed to a clinical goal all the time.
Sure.
Yeah, we switched from doing the I mean, we still follow, you know, who improves A1C and all that jazz, but
Sure.
our focus has turned to mental health the last couple of years, just because we do have one of the biggest mental health facilities anywhere. And a lot of the vets coming back are really young, like we'll get 19, 20-year-olds who are now vets for the rest of their life. But we've started to do more on just how the confidence that they feel, or how do they feel that it's interfering with life in general, and is that improving as they're getting education and going through the process, or isn't it? So finding ways to just help them feel better about, this is the rest of my life, you know.
Right. Okay.
We've
Has
done a
anybody
couple.
worked on like referral processes, like from primary care?
Yeah, I was just going to comment on that. That I did that a couple years ago as one of my quality improvement, and ours was about it was kind of almost like a marketing CQI. So we had I developed a pretty consistent message, and I think you could probably use what they have on the tool, that DSMES toolkit from CDC now, but it was similar to that, and then I went to all the, I think I had like a number of primary care clinics that I was targeting, and I wanted to get whatever that number was. Let's say it's 80. I wanted to get to 75% of those was my goal. And then we delivered the message at all the clinician meetings. So it was a consistent message at every clinician meeting, and then had some like handouts that we left, and then we measured referral increase.
Okay. That's great. Thank you.
We also did one a few years back on our insulin pump process. we implemented a pump liaison and kind of measured because we found that we could get patients started on the insulin pumps, but they were falling through the cracks after for follow-up. So we were trying to measure impact on follow-up.
Okay, great.
Thank you. Those are some great suggestions. Anybody else?
Thank you.
As far as getting questionnaires, this is Jennifer, and or goals, we are having marketing actually turn some of our like our initial assessment and our goal sheet into virtual forms that we can actually push out in my chart. And so they're not live yet, so I can't speak for it yet, but that is what we have in process.
Wonderful. Thank you for sharing. And I would just put a plug in too that MDH with our new grant, we are doing some focus on diabetic retinopathy screening and CKD screening. And specifically, we're working with the National Kidney Foundation to work with different clinics to increase their screening. So if you want to do something very clinical, with a co-condition of the CKD or diabetic retinopathy, let me know. We can maybe kind of tag team for both of us. So that's also an option. Right. Any other questions, concerns today before we head off for our Friday afternoons? Wonderful. Well, I appreciate you joining today. Our next meeting is Friday, June 14th. Topics to be determined. If you have anything specific that you'd like to hear about or something that you're struggling with that we could ask for a speaker to come into, please let me know. And watch your inboxes. The recording of this meeting will be sent out within probably the next 2 weeks. And as always, if there's anything MDH can do to support you and your diabetes education program, please let us know. Have a wonderful weekend, and we'll see you in June. Or May 3rd, for those who are going to the conference, May 3rd.